All right. So my name is Ryan Dickerson. I am a student in Brainstem medicine class of 2025, and this is an attempt to create a resource for a quick anatomy overview leading up to step one. And this particular video is going to cover some neuroanatomy. This resource is being brought to you by Scrubs, which is the student collaborative resources for understanding and Brody success. And some of the resources that I used to put this together was utilizing questions from UWorld, ScholarRx, the 100 Anatomical Concepts from St. Matthew's School of Medicine PowerPoint, the Brainstem lesson course pack, and Nodal the Human Brain. And this was just to get a sampling of some of the most common clinical correlations that come up. Honestly, there is probably 8 hours worth of material here to go through. So what I've done is just take some of the highest key points, and we're going to talk through those briefly. But once we start going, it's going to move pretty quick. And again, this is just a brief sampling rather than a more in-depth dive. So just giving a mission statement for what Scrubs is. So Scrubs is a student derivative initiative that's developing supplemental resources for future and current cohorts that pass through Brody. This is done by students who have been walking through the same shoes. So hopefully kind of giving a resource from students who have been through the same material as students who will be using this resource. So if this is something you're interested in becoming a part of, by all means, we are happy to have you on the team. And as a disclaimer, this is made by students, so this is not made by faculty. So most of this disclaimer does not apply for this situation. However, do keep in mind that there could be errors within this video. So if that is the case, please go by your primary documents that you're using to study for step one. And with that, we're going to go ahead and start running through some of the most common clinical correlations that I could find throughout these multiple resources. So quick structural review, looking at the dural folds and dural venous sinuses. This comes up relatively often. So going through the dural folds real quick, we've got the falx cerebri. So when we see the word falx, we're going to be thinking a superior to inferior infolding of the dura. And another important point that these folds are made of the dura mater. It has a periosteal layer and a meningeal layer, and that is what is going to form your dural folds. So the falx cerebri. We see our tentorium cerebelli coming here, and when we think tentorium, think horizontal plane. So this is going to separate our cerebrum from our cerebellum. And then not shown here below the tentorium, that is where you're going to have your falx cerebelli, which is going to split a portion of the cerebellar hemispheres. And then up here in the front is the diaphragm ocella. What is most important about the structures of the dural folds is that within the dural folds we have the dural venous sinuses, and the dural venous sinuses are allowing for cerebrospinal fluid that is coating the interior portions of the brain to flow into the venous system, and it does that through the arachnoid granulations, which we'll see on the next slide. And we'll talk about a little bit more of how CSF flows throughout the brain. But what I want to point out here is that you have the superior sagittal sinus. The superior sagittal sinus is at the superior pole of the falx cerebri, so it's going to be running around the top here. Then if we go inferiorly, we have an inferior sagittal sinus, which then drains into the straight vein, which is going to drain back into the confluence along with our superior sagittal sinus. So the confluence of sinuses back posteriorly. The internal structures of the brain are going to be drained by the great vein of Galen, right, which is going to be running towards more midline, and there's some other veins that break off there, but I don't imagine those are going to be super high yield when it comes to step review. But the great vein of Galen also drains into the straight vein, or the straight sinus, which drains back into the confluence sinuses. Now, from the confluence, CSF is going to flow laterally through the transverse sinuses. So the transverse sinuses are found right at the junction of the tentorium cerebelli and the skull. So it's I should point out that the dural venous sinuses are pouches between the periosteal meningeal layer of the dura, which is allowing them to communicate with venous and cerebrospinal fluid. And then as we go from the transverse sinus, we are then going to go through the sigmoid sinus. Sigmoid sinus is going to be located down in this region. And then from the sigmoid sinus, we're going to go through the jugular foramen into the internal jugular vein. So the most important thing to take away from this is that, in general, CSF is going to flow from the superior sagittal sinus down to the confluence, transverse, sigmoid, into the internal jugular vein. The end goal of the cerebrospinal fluid is to get into the venous system to circulate and be reuptake throughout the body. So the reason that it's important to know the pathway of cerebrospinal fluid is because of hydrocephalus. So going really quickly through this image, cerebrospinal fluid is made by the choroid plexus. You have choroid plexus in all of your ventricles, your lateral ventricles, third ventricle, which is seen here, and your fourth ventricle. But we're going to start at the most superior regions, which is your lateral ventricle. So in the lateral ventricle, you've got choroid plexus making CSF. It is then going to communicate into the third ventricle via the foramen of Monro. So you have a foramen of Monro on either side of the septum pellucidum, a little bit inferior to it, and that is going to allow communication between the lateral ventricles and the third ventricle, which is pictured here. From the third ventricle, we are then going to go through the cerebral aqueduct. So the cerebral aqueduct is really a continuation between the third ventricle, fourth ventricle, and the central canal of the spinal cord, but it is a portion of the brainstem. So we have the cerebral aqueduct coming down, and then we open up into the fourth ventricle. From the fourth ventricle, there are a couple of different avenues that cerebrospinal fluid can go. One is on either side of the fourth ventricle, and that is the lateral apertures of Luschka. So lateral L for Luschka, which also has an L. And then we also have an outflow tract that goes down the median aspect, which is the median aperture of Magendie. So M and M, median for Magendie. Now, once we get, and then lastly, we're going to have a little bit of CSF that's going to be flowing into the central canal as well. Now, once we escape the fourth ventricle, and we're now into the space between the brain and the more superior meninges, we are going to be in these cisterns. So these cisterns all have different names. Again, something to look over before step, but not something that I imagine will be extremely high yield. So as we're moving up, we then move up into our arachnoid villi, our arachnoid granulations, and from our arachnoid granulations, we are then going to get into that superior sagittal sinus, and then flow down into the confluence of sinuses, and then eventually we're going to get into the internal jugular system a little bit further down. So that's a very brief overview of the cerebrospinal fluid pathway. But what's really important is differentiating communicating versus non-communicating hydrocephalus. So the way that I think about this is communicating hydrocephalus is anything that allows CSF to get into the cisterns. So anything that allows CSF to get into the cisterns is going to be considered communicating hydrocephalus. Now, how do we get hydrocephalus, ballooning of the ventricles, if you can get into the cisterns? Wouldn't that allow you to go up to the arachnoid granulations and communicate down? Well, one of the most common presentations of communicating hydrocephalus is going to be meningitis, which then scars and scars down on these arachnoid granulations, meaning that the cerebrospinal fluid is stuck within the cisterns, which will eventually back up into the ventricles as well. But that is communicating hydrocephalus. Non-communicating hydrocephalus is probably the more common kind of hydrocephalus, or at least when we're thinking about hydrocephalus. This could be due to a developmental issue. This could be due to a tumor. It could be due to a lot of different things. But non-communicating hydrocephalus means that there is cerebrospinal fluid being produced by the ventricles, and then at some point along this pathway, before it exits into the cisterns, there is a blockage. So one of the common places that might happen would be the cerebral aqueduct. For example, if there's a pineal gland tumor, which then compresses the cerebral aqueduct, or a tumor around the tectum or midbrain, or you could have a tumor of the choroid plexus in the region of the foramen of Monro, which could also cause unilateral lateral ventricle hydrocephalus. So those are all examples of hydrocephalus, both communicating and non-communicating. And typically this is going to be treated with a shunt. It's going to shunt cerebrospinal fluid into some other location, usually in the GI system. Okay, now going really quickly, there's a couple of foramen of the skull that are super important because they have vasculature or nerves that are associated with them. The first one is going to be the olfactory bulb associated with the cribriform plate. The reason I'm pointing this out is because the cribriform plate, a bunch of little holes, very easy when you have head trauma to have that go back and forth like a cheese grater, and then you've got damage to your olfactory bulb. So that's going to be cranial nerve 1 associated. Then you have over here your foramen ovale. The foramen ovale is going to allow V3, or the mandibular branch of the trigeminal nerve, to communicate. So that's going to be doing the muscles of mastication along with the sensation of the face, at least the lower portion of the face. So that's an important structure to keep in mind. We have the middle meningeal artery going through the foramen spinosum, which is the most lateral of these holes. There's actually 3 holes that we can see here, and I remember them SOL, spinosum ovale, and foramen lacerum, because if you don't know these, you are shit out of luck. And then the ones that are most associated with structures would be the spinosum with the middle meningeal artery and the ovale with V3 or the mandibular branch of your trigeminal nerve. Now, I wanted to point out the optic canal, which is located right here. You can see it's just lateral to the diaphragm ocella, and the optic canal is going to have the optic nerve and ophthalmic artery communicating through that. And then we have right here, it's kind of hard to see. It's also located on the other side, but this is your internal acoustic meatus. This is where cranial nerves 7 and 8 are going to be communicating. And specifically for cranial nerve 7, I'm going to go through the pathway real quick as it exits the skull. You go through the internal acoustic meatus, you go through the facial canal, then there's a facial canal hiatus that allows some components of the facial nerve to communicate in this region, but the majority of it is going to communicate inferiorly, and it's going to exit between the styloid process and the mastoid process through the stylomastoid foramen. Okay, so that's where it's going to be exiting the skull, and then it's going to go into the parotid gland, become plexiform, and supply regions of the face. Now, number 6 here, this is your internal jugular foramen. Your internal jugular foramen has cranial nerves 8, 9, and 10 associated with it. So that's going, sorry, not 8. 8 should be up here. It's going to have 9, 10, and should be 11. So 9, 10, and 11. And that's your internal jugular foramen. So ignore the 8 here. 8 is going to be up here with your internal acoustic meatus, and this should be 9, 10, and 11. Associated right here. Now, cranial nerve 12, the hypoglossal nerve, is going to come straight in front of the clivus. Now, this is a cartoon image, and this is probably a little bit easier to study, but going over some of the same things. This is talking about the foramen, where they're associated with. Is this going to be the anterior cranial fossa, middle cranial fossa, posterior cranial fossa, and different structures that you need to know that are associated with each. I do find that this is a pretty easy second-order question for them to ask on step. So you have damage to a nerve, you recognize that nerve is damaged, and they ask you what hole it goes through, and then all of a sudden that question got a lot harder. Now, what is nice about this image, the superior orbital fissure, you can see the nerves that run through that. These are going to be the same nerves that are running through your optic chiasm, or sorry, not your optic chiasm, your cavernous sinus, which we're going to talk about in just a moment, so that's a little bit easier to remember. The optic canal, again, cranial nerve 2, ophthalmic artery. And then your foramen rotundum, ovale spinosum. The rotundum is actually a more anterior hole. That's going to allow V2 to communicate through. And then, let's see here. Foramen ovale, again, communication for V3. Foramen spinosum, middle meningeal artery. Again, you can read through this chart on your own. But I do feel like this is a pretty good overview of the important structures that you're going to need to know. Now, talking about the cavernous sinus is important because it can become affected. It allows communication between the face and the brain. But again, this is a sinus like all the other sinuses, dural venous sinus. It sits on either side of the pituitary gland. This is going to be on either side of the diaphragm ocella, which again is part of your sphenoid bone. What I want to point out here is the particular orientation of the structures that are located. So, for instance, if you have swelling of the cavernous sinus, then you could have damage to all of these nerves or infection, all of these nerves along with this vessel. So the vessels that you need to know, or the structures you need to know, oculomotor nerve, trochlear nerve, V1, so that's the ophthalmic branch of the trigeminal nerve, and the maxillary branch of the trigeminal nerve, along with abducens and the internal carotid artery. So the way that I remember this is O Tom the cat. So over here on the lateral borders, going from superior to inferior, you have cranial nerve 3, 4, V1, V2, and then you have cranial nerve 6, and then you have an artery. So it helps just 3, 4, V1, so 5, 5, 6, and then the internal carotid artery. So again, I think if you have a general idea of where these structures are located as they're passing through the cavernous sinus, the majority of these are then going to pass through the superior orbital fissure as they're going more anteriorly towards the eye. Then that should put you in pretty good shape with this particular correlation. Now, one thing that I do think is pretty important are the different types of brain hemorrhages. So the difference between epidural, subarachnoid, subdural hemorrhages, and along with intracerebral hemorrhages does come up pretty often. So the epidural hematoma, so that's going to be above the dura. That's going to be between the skull and the dura. That is going to be due to the middle meningeal artery, and that's the lemon shape on CT. So, and the reason for that is because the dura is tightly adhered to the the bone, and because it's tightly adhered to the bone, you can only really get a little bit of an outpouch in the region where the artery is damaged. You're not going to get communication across different sutures of the skull. So that is going to be middle meningeal artery damage, which is typically I'm going to present with someone hitting their head, the lateral portion of their head, and that is going to be because they are damaging the pterion. The pterion is the juncture where many of the bones of the skull are fusing together in this lateral region. So damage there would cause damage to the middle meningeal artery, which remember was going through the foramen spinosum, and then that can cause an epidural hematoma. This is going to be one of those presentations where they get up, they have a little latent period, and then all of a sudden they crash really hard. So that is the epidural hematoma. The subdural hematoma, this is commonly due to damage by the bridging veins. So bridging veins are venous blood. So this is a slow bleed. And remember, you can have subdural hematomas that are chronic in nature, so it actually doesn't bleed enough to cause significant damage, and then over time, you get macrophages that come in and eat up the heme, and then they're going to become hemosiderin-laden macrophages and different things of that nature. But that is the subdural hematoma, slow bleed, done primarily by the bridging veins. Then the last major bleed is the subarachnoid hemorrhage. This is typically due to the circle of Willis aneurysm, like a Berry aneurysm. This is going to be a big bleed. All of your major vessels that supply the brain are in the subarachnoid space. So that's going to be your circle of Willis, your basilar artery, all of those different vessels. So this is going to be the one, oh my gosh, this is the worst headache of my life, thunderclap headache. I need something done now. That's going to be your subarachnoid hemorrhage. And the last one, I want to talk about the intracerebral hemorrhage. So this is hemorrhaging into the deep regions of the brain. This is typically going to be done to lenticulostriate arteries, so Charcot-Bouchard aneurysms or things of that nature. And there's other causes to this, but think hemorrhage into the deep brain regions is going to present significantly different than a lesion of the subarachnoid hemorrhage, because these deep brain regions are going to control the basal ganglia. It's going to have the internal capsule coming through, so this could present in significantly different ways that you're going to be able to clinically recognize compared to these other hemorrhages. Now, again, moving fast through all this material, talking about the brainstem, just really briefly. Big things that I want to point out about the brainstem is you have the medulla more inferiorly, the pons, and then as you go more superiorly, you have the midbrain until you get into the thalamus and hypothalamus region. So the major things here is that in the brainstem, you're going to have your cranial nerves exiting the brainstem. So what's great about this is if you start from the top, you can just work your way down cranial nerve 1 all the way through cranial nerve 12. What's also nice about this particular image is it lets you know what cranial nerves are associated with what region of the brainstem. So starting from the top, cranial nerve 1, that's the olfactory tract right here, olfactory bulbs. Cranial nerve 2, that's your optic nerve. Again, optic chiasm located right here. You can see that is right anterior to the infundibulum, or the pituitary stalk, which is located right there. What I do want to point out here is the circle of Willis. That's going to be located right in the same region as well. Okay, so keep that in mind. So damage to the circle of Willis or the basilar system or any of these vessels is going to have significant defects that are notable based on the region that the lesion occurs. Midbrain, you've got cranial nerve 3, oculomotor, and trochlear nerve. Point about the trochlear nerve is remember the trochlear nerve is exiting through the posterior portion of the midbrain, whereas the oculomotor nerve is going to be exiting through the interpeduncular cistern, which is in between the two cerebral peduncles. Then we get into the pons. The pons is going to have a lot of different cranial nerves. Trigeminal nerve is probably the most recognizable. This is going to be coming out laterally. It's pretty big, and again, it has this V1, 2, and 3 segments. Then you've got the medial portion of the pons that coming out mostly right off the front anteriorly. This is where you're going to have the abducens nerve. So abducens nerve, remember, abducens cranial nerve 6. So you have SO4, superior oblique, innervated by cranial nerve 4, which is the trochlear nerve, and then LR6, which is the lateral rectus, which is innervated by the abducens nerve. Now, going over a little bit more laterally, we're going to have the facial nerve, so cranial nerve 7, and then we're going to have our vestibulocochlear nerve. Again, those are both going through the internal acoustic meatus in the skull to get to their terminal destinations. Now, as we look at the medulla is going to have all the rest of the cranial nerves, so this is going to be cranial nerve 9, 10, 11, and 12. And what I want to point out about 9 here, let's find it. 9 located right there, glossopharyngeal. 10, that's your vagus nerve. 11, spinal accessory nerve. This is actually coming from portions of the spinal cord, so you can actually see it run up. And then cranial nerve 12, your hypoglossal nerve located right here. Now, what is relatively important to note is that the nuclei for these nerves are going to be located posteriorly in the brainstem. Okay, so nuclei for the cranial nerves located posteriorly in the brainstem for pretty much all of these regions. An exception to that would be the trigeminal nerve and facial nerve. They have a little bit more complex they have a little bit more complex nuclei when it comes to the brainstem, but for the majority of the rest of the nerves, think most posteriorly, right before the cerebral aqueduct or periaqueductal gray, fourth ventricle, those regions, that's where you're going to see the cranial nerve nuclei. So any vessel that you see wrapping around here, going posteriorly, so that'd be your ACA here or your PICA down here, your superior cerebral artery, superior cerebellar artery, posterior cerebral artery, those could all potentially damage those posterior nuclei. Okay, so speaking of that, I want to talk very briefly about some of the syndromes that you need to know. So the one that I'm really going to focus on is lateral medullary plate syndrome. So this is when you've got damage to the lateral medulla, and this is because of the PICA being damaged. So this is an infarct. So what I want to point out here is there are some tracks that may be worth remembering. We're going to look at the very end of this video, looking at how to localize damage, and part of that is going to be going over very briefly some of the tracks. So what I want to point out here is with lateral medullary plate syndrome, you have the loss of a couple of different nuclei. You have loss of the vestibular nuclei, which are located in the most lateral portions of the medulla. They're also going to be located in the more lateral portions of the pons if we move a little bit anterior or superiorly. So that's going to give you your vertigo, your nystagmus, your vomiting. Over here in this lateral region, you have your inferior cerebellar peduncle. So this is going to cause ataxia on the same side as the lesion. The spinal trigeminal nucleus. The spinal trigeminal nucleus is going to be the nuclei for pain and temperature when you're talking about the trigeminal nerve. And because you're damaging the nucleus here as opposed to the tract, you're going to be damaging ipsilateral pain and temperature to the face. So that's that in red here, ipsilateral pain and temperature to the face. However, because you're damaging the spinothalamic tract, which is pain and temperature from the lower part of the body, that crosses as soon as it hits the spinal cord. So you're going to lose pain and temperature on the contralateral side of the body. So that's over here in blue. The nucleus ambiguous is going to have the glossopharyngeal nerve components, or motor components for that. So the glossopharyngeal motor components, that's going to cause diminished gag reflex, dysphagia, and dysphonia. Right. And the one other thing that I want to point out here is you also get Horner syndrome because the sympathetics that are going to the upper part of the face are actually running through the posterior portion of the medulla here. So when you have lateral medullary plate syndrome or Wallenberg syndrome, you could also get Horner's syndrome components going in there. And I feel like Horner syndrome is something that comes up frequently enough that that's a pretty big clue to help you clue into this lateral medullary plate syndrome. Other things that you do want to keep in mind, damage to the brainstem. That's going to be specific to specific vessels that I would review. Weber syndrome is the posterior cerebral artery. Weber syndrome is going to be damaging. If you think about the PCA, that is going to be located just superiorly to the oculomotor nerve coming out of the interpeduncular cistern. So the posterior cerebral artery is going to be damaging the region of the oculomotor nerve. So think defects with the eyes. That's going to also interfere with the sympathetics and the parasympathetics that are associated with the oculomotor nerve, as well as some of the other structures in that region. Now, medial medullary plate syndrome, so that would be damage to this medial aspect here. Medial medullary plate syndrome is mostly going to be due to the anterior spinal artery or the vertebral arteries as they come through in this region. And then lastly, damage to the anterior pons, that's the basilar artery. That's going to cause pretty significant defects. That's your corticospinal tract running down right at the anterior portion of the pons. So that could cause locked-in syndrome. But again, these are things that I would go into a little bit more detail with on your own. But just to point them out, Weber syndrome, medial medullary plate, and anterior pontine are definitely things that I would take a look at if you have the time. Now, granted, we've already talked about a good amount of this in our other reviews, but a quick review of the vasculature, talking about the circle of Willis and the basilar system. What I want to point out is you have your vertebral arteries running up These are running through the transverse processes of the cervical vertebrae through the transverse foramen. That's specific for the cervical vertebrae. And then you have the vertebral artery running up. It joins with your other vertebral artery to form the basilar artery. Now, usually coming off the vertebral arteries as you're getting into the brainstem, you're going to have the posterior inferior cerebellar artery, or the PICA. As you go more superiorly, you have the ACA, the anterior inferior cerebellar artery. And again, these names are pretty descriptive into where they go with the brain. You can also see the regional distribution on this image on the left. Now, as you go superiorly to the basilar system, you're then going to have the superior cerebellar artery. So that's going to be the last vessel that's going to be doing primarily cerebellar function. We go up anteriorly a little bit more, and superiorly in this particular view, then you're going to have the posterior cerebral artery. So posterior cerebral artery coming right through here. Now, what I want to point out is the oculomotor nerve comes out right here where the pointer is now. So the oculomotor nerve is going to come out between the superior cerebellar artery and posterior cerebral artery. So that means that any kind of lesion to the posterior cerebral artery or the superior cerebellar artery could cause damage to the oculomotor nerve as well as it's moving forward to the eye, again, damaging both the motor components as well as the parasympathetic components that are contained within that nerve. Now, getting up into the circle of Willis, then we're going to have the posterior communicating arteries. And from now on, all of these major branches are going to be branches of the internal carotid. So here's your internal carotid here. And you see in green here, this is the posterior communicating artery. From also coming off the carotid, you have the middle cerebral artery, which is going to then go and supply the lateral portions of your brain. The anterior cerebral artery, which is going to go anteriorly, and this is going to wrap around and supply the medial portions of the brain. Communicating between the two is your anterior communicating artery. Now, you do have a couple of other vessels that are coming off in this region that are just worth pointing out. Coming off the internal carotid artery, you have your anterior choroidal arteries, and you have some lenticular striate arteries. Lenticular striate arteries are going to come up again in just a moment. Now, thinking about strokes, when it comes to the big vessels that are in your brain, again, these are subarachnoid hemorrhages, or it could be an ischemic stroke, then we want to think about what is the regional distribution for each one of these vessels, which is shown here. So this shows you your anterior cerebral artery, middle cerebral artery, and posterior cerebral artery, and you can kind of mix and match what kind of deficits would you expect to see with each one of these vascular occlusions. So talking about the anterior cerebral artery, the anterior cerebral artery is everything that is in yellow here. So you can see that it's mostly doing the very superior medial aspects from a lateral view, and then it's doing the majority of this medial anterior portion of the brain. So what's important to note here is this is where the cingulate gyrus is. This is where a lot of your limbic system is housed. Right here is your paracentral gyrus. The paracentral gyrus is going to be doing so it is the precentral gyrus and the postcentral gyrus on the medial aspect that makes up the paracentral gyrus. So that is doing the lower body, both motor and sensory. So you could have defects there, and that's going to be contralateral to the defects. And then the middle cerebral artery, again, mostly doing this lateral aspect. What I want to point out here, if it's on the left side, then you're going to have damage to Broca's area and Wernicke's area. As well as right in this region, you have your primary auditory cortex, so that could also be damaged as well. And then there's also other associations with the parietal lobe, the frontal lobe, and temporal lobe that are worth keeping in mind, but really Broca's area, Wernicke's area, your precentral and postcentral sulcus, precentral and postcentral gyruses. So this is going to be loss of motor and sensory to the contralateral upper body, that and face and things of that nature. Then that's really the big presentation for the MCA. And then lastly, the PCA is doing a lot of this posterior region of the brain. What's most important here is back here in the calcarine sulcus. This is where you're going to have your primary visual cortex. So you could have vision loss if you have damage to the PCA. And we'll talk about the pathway of the optic nerve in just a minute, which will go through a little bit more in detail of where those lesions could lie. Now, talking a little bit more about strokes, we did mention the lenticular striate arteries, which are primarily coming off of your middle cerebral artery or your internal carotid artery within that region. The lenticular striate arteries are doing those deep brain regions. And because they're doing those deep brain regions, that could cause damage to the caudate nucleus, the thalamus, your putamen, your globus pallidus, your substantia nigra, subthalamic nuclei. All of those deep brain regions could be damaged with the lenticular striate vessel occlusion or hemorrhage. And then the other thing to note is the internal capsule, which is fibers coming from the cortex running down into the brainstem to get to the rest of the body, could also be damaged with the lesion here. So if you think deep brain lesion, hemorrhage, or infarct, you're thinking lenticular striate arteries for the most part. And that's going to be lacunar strokes or Charcot-Bouchard aneurysms fall into that ischemic and hemorrhagic components when you're thinking about lenticular striate arteries. Now, something that I typically find to be quite complex is thinking about the basal ganglia. I've seen a couple of questions that have really forced you to understand the generalities of the basal ganglia, so I'll try to keep this relatively brief. There's a couple of specific clinical correlations that you can point out that are associated with pathology, so I'll point those out as we go along. So the first thing I want to point out is the structure of the basal ganglia over here on the image on the right. First, we have the caudate nucleus. Remember, the caudate nucleus is going to form the lateral wall of the lateral ventricle. It's going to be located inferiorly on the lateral aspect if you're looking at the lateral ventricle, but as you go into the temporal horn, then it would form the roof of the temporal horn. Really not super important, but just a little thing to keep in mind. You have your thalamus located in the more midline, and then over here in the lentiform nucleus, which is a combination of the putamen and globus pallidus, you have the putamen more laterally, globus pallidus externa, globus pallidus interna. And then down here we're going to have our subthalamic nucleus. So if there's our thalamus, that makes sense. It's right below that, subthalamic nucleus. And then we're going to have our substantia nigra right here. So as we move over to the left, this is the more functional image. What I want to point out is we're ignoring the caudate nucleus in this pathway here, but typically from the motor cortex, you've got signaling that goes to the caudate nucleus. The caudate nucleus is then going to send excitatory fibers to the putamen for the putamen to have its actions. But starting with the putamen is sending inhibitory fibers to both the globus pallidus externa and globus pallidus interna. Now let's follow the pathway of the globus pallidus interna first. So as we sent, the putamen sends inhibitory fibers to the globus pallidus interna. Globus pallidus interna would then send inhibitory fibers to the thalamus, which inhibits motion. So by sending inhibitory fibers to the globus pallidus interna, this is going to be pro-motion. So this signal here, inhibiting the globus pallidus interna, is going to be pro-motion. If we go to the indirect pathway, which is going through the globus pallidus externa, and you're going to see why this is indirect in just a second, we go from the putamen, inhibiting the globus pallidus externa, which would then reduce inhibition to the subthalamic nucleus. The subthalamic nucleus is then going to send excitatory fibers to the globus pallidus interna, and if you have excitatory fibers going to the globus pallidus interna, you are then going to have inhibition of the thalamus. So inhibition of the globus pallidus externa allows disinhibition of the subthalamic nucleus, allowing excitation of the globus pallidus interna, inhibiting the thalamus. What I like to think about here is everything's going through the globus pallidus interna, just the direct pathway or the indirect pathway. Now, what I want to point out is that the subthalamic nucleus, the substantia nigra, not subthalamic nucleus, is going to release dopamine. And we can think about Parkinson's disease. The loss of dopamine, that inhibits motion. So how does that happen? Well, there's two different dopamine receptors here. There's a D1 receptor and a D2 receptor. The D1 receptor is going to be excitatory in response to dopamine. The D2 receptor is inhibitory in response to dopamine. Both of these together are going to be pro-motion. Now, the excitatory pathway is going to excite the direct pathway. So if you're exciting the direct pathway, once again, you are inhibiting the globus pallidus interna. That is going to allow you to move because the globus pallidus interna normally is inhibiting fibers going to the thalamus. Now, by inhibiting the indirect pathway, so you're inhibiting this fiber here, you're no longer inhibiting the globus pallidus externa, which means you can inhibit the subthalamic nucleus. So if the subthalamic nucleus is inactive, then you're no longer getting activation of the globus pallidus interna, which in turn means that you have movement. So, in general, the D1 and D2 receptors together, one is excitatory, one is inhibitory, these are both going to allow movement. And the way that I keep this in mind is the substantia nigra, which is releasing dopamine. If that is damaged, we are going to get Parkinson's disease. Okay. So so Parkinson's, loss of dopamine, inhibiting motion. Other clinical correlations that I want to point out is that the caudate nucleus, remember those CAG repeats with Huntington's disease, that can cause inhibition of movement as well, because again, we said the caudate nucleus is sending excitatory fibers to the putamen for pro-motion capabilities. And then lastly, the subthalamic nucleus has an inhibitory role. So the subthalamic nucleus is acting on the globus pallidus interna in an excitatory fashion, which will then inhibit the thalamus. So in general, the subthalamic nucleus is inhibiting the thalamus via this pathway on the ipsilateral side. So if you have loss of the subthalamic nucleus, this is where you're going to get hemibolismus, which is those large, rapid movements on half of the body because you have lost the subthalamic nucleus on a unilateral side. All right, and that's a brief overview of the basal ganglia. Again, it gets pretty complicated, but I think these are the three main points to take away, that these are locations of damage and how to connect those with the anatomy that's. Okay, now one thing that I have seen come up in a lot of questions is different forms of herniation. So I'm taking this from first aid, but a couple of points I just want to point out as really big things to know. The first one is subfalcarin herniation. So subfalcarin herniation is herniation underneath the falx cerebri. So again, falx cerebri going superior to inferiorly. The main thing that is going to herniate under the falx is going to be the cingulate gyrus. So the cingulate gyrus can herniate under. This can also, so when you have the cingulate gyrus herniating under, part of the anterior cerebral artery is running through the sulcus right above and below the cingulate gyrus. So the one below is the pericolossal artery, and then the one above is the colosso-marginal artery. Both are branches of the anterior cerebral artery, but in general, you're going to get compression of that anterior cerebral artery, which means that you can damage everything in the midline. So this can be present with contralateral lower limb, motor, sensory, and limbic defects, because again, those are all housed in the medial aspects of the brain in this region. So, but in general, know that that is compression of the anterior cerebral artery. It's the same deficits that we saw when we were thinking about stroke to the anterior cerebral artery. But this is due to a falcarin herniation. And I have seen this question show up on UWorld. Okay, and then talking about the second one, this is just central transtentorial. So transtentorial means through the tentorial notch. This one's relatively bad. I don't usually think that we'll see this one. I haven't seen any questions on this one, but that's going straight down. One that I have seen is the uncal herniation. So the uncal herniation is just the uncus, which is the more medial aspects of the parahippocampal gyrus herniating down. And what's important about this is that the uncus is directly beside cranial nerve 3. So if you have the uncus herniating down, this can cause damage to the ipsilateral cranial nerve 3, which is your oculomotor nerve. And again, because the oculomotor nerve contains parasympathetics, that can, if that is damaged, you can result in an ipsilateral blown pupil. There's also with cranial nerve 3 compressions, you're going to be thinking that the down and out. So because of loss of cranial nerve 3 on that side. The last one is the cerebellar tonsils herniating down into the foramen magnum. Again, this is the reason why we don't want to do a spinal tap if someone has high intracranial pressure, because you can cause cerebellar tonsil herniation, but that's herniating through the foramen magnum. And the big thing here is it says comorbid death. That's pretty significant. That would cause, I mean, this is the big risk for doing those spinal taps, but you would have to include the brainstem. So the main thing, if it's just a little bit of a cerebellar tonsil herniation, then you're going to be thinking cerebellar defects. And depending on what side is damaged, that would be on the ipsilateral side, because cerebellum controls ipsilateral body motion. Now, one thing that I do imagine will come up again and again and again is the pathway of the optic nerve. And I have to draw this out every single time because I always forget medial, lateral, up, down, the difference between visual fields and retinal fields. But something to keep in mind is when we're thinking about the pathway of the optic nerve, and I'm going to talk about the retina fields here. So retinal field in this medial aspect is going to cross the midline, same as the contralateral side. So on either side, the fibers that are crossing the midline were coming from the medial aspect of the retina, and they're going to cross. If it was on the lateral aspect of the retina, then it's going to stay on the same side in which it originated. So if it started on the lateral side over here, the temporal side is going to stay on that same side. Now what I do want to point out though is because this is the temporal retina, that is going to be looking across to do the middle visual field. So there's a difference between the retinal field and the visual field. The visual field is what's shown up here in the front. The retinal field would be this region back here. So when I'm typically going through these, I think of the retinal field, and then I just have to flip it into the visual field. Now, one of the correlations here is the pituitary mass. Pituitary mass, because again, the pituitary sits just posterior to the optic chiasm. And the pituitary adenoma can push on the optic chiasm, and that would result in loss of the fibers that are going from the medial aspect of either eye. And again, if it's from the medial aspect of the eye, that is going to be your temporal visual field. Right, so this is going to cause bilateral temporal hemiopia, which is going to be number 2 here. That's one of the common presentations of a pituitary adenoma. Other things that I want to point out here is that as you're going through the optic tract, you do have Meyer's loop, which is going down inferiorly. I don't think that's super important, or the optic radiations. Knowing those names isn't probably the most important. What is important to know, however, is everything that's over here. So this is going to be at what region of damage am I going to have a presentation of a visual defect. And so the ones that I really want to point out, we understand if there's loss of one, this could be a defect that's back here in the back where you've just lost everything. But primarily you're going to have a defect in the optic nerve. Bitemporal hemiopia, again, that's going to be optic chiasm damage. Optic tract is going to present with one side or the other. So not bitemporal, but either left or right hemiopia, depending on which optic tract region is damaged, the left or the right. And then really getting back here into Meyer's loop and the optic radiations. So the optic radiations are superior. Meyer's loop is inferior. These superior fibers are taking information from the superior retinal fields. So if they're taking information from the superior retinal fields, that means that they're corresponding to the inferior visual fields. So that's why damage to this optic radiation here, which again, superior retinal fields, will correspond to inferior retinal field damage. And Meyer's loop is going to be the opposite because it is taking inferior retinal field information. It is going to cause damage to the superior visual fields. Okay. And then lastly, I want to point out, you see that the macula is spared here in number 6. The reason that macula is spared is because the macula is the most posterior portion of the calcarine sulcus, or it's represented by the most posterior portion. So if you have macular sparing, then there has to be some kind of blood flow that's getting to that most posterior pole. In this case, it shows if the posterior cerebral artery infarct is occurring, then maybe there's some other blood flow back here from like your superior cerebellar artery. And then if the macula is damaged on its own, that's likely to happen in the eye itself. Okay, so the last thing that I want to cover is talking about localization of damage. So there's going to be 2 slides on this. This one is kind of overwhelming, but the big points are in boxes here. When you're thinking about localizing damage, what I'm talking about here is localizing damage left and right, and at what level? Is this in the cortex? Is it in the thalamus? Is it in the brainstem? Is it in the spinal cord? If it's in the brainstem, is there any way that I can tell more specifically where that damage is located? So when we're thinking about this, we're going to start with the fiber pathways. The first fiber pathway I want to talk about, and this is again going to be a review of the fiber pathways, is going to be the dorsal column medial lemniscus pathway. Now the dorsal column medial lemniscus pathway is going to be your tactile sensation, so tactile and proprioceptive sensation. Now that is going to enter the spinal cord and run ipsilaterally. So it's running on the same side in which it entered all the way until you get to the top of the medulla. At the top of the medulla, this is where you're going to have the nuclei. So this is nucleus gracilis, nucleus cuneatus. Cuneatus corresponds to upper body, gracilis corresponds to lower body. Once those synapses, those are then going to cross the midline and run through the medial lemniscus tract up until they get to the brain. So first thing that's important to note, that you have crossing over happening at the top of the medulla when it comes to sensory information. From there, it's going to run contralateral all the way until it gets to the brain. When it comes to pain sensation, this is going to be your spinothalamic pathway. Your spinothalamic pathway crosses immediately as soon as it hits the spinal cord. So it's going to hit the spinal cord, it's going to synapse, and it's going to cross. One thing that is important to note is that you do have Lasauer's tract. Lasauer's tract allows it to go 1 or 2 spinal cord segments superior to the damage before it crosses. This is important when you're trying to differentiate Brown-Sequard or other spinal cord lesions. But think coming into the spinal cord, immediately crossing, running contralateral. And then lastly, descending pathway. So this is going to be a motor pathway coming from the cortex, running on the same side as it's coming from the cortex until you get to the bottom of the medulla. So the difference here was top of the medulla when you're looking at the crossing over of the nucleus gracilis and nucleus cuneatus versus the bottom of the medulla when you're talking about the decussation of the pyramidal decussation. So the pyramidal decussation allows motor corticospinal fibers to cross, and those are going to run contralateral for the remainder of their route. So when you put these three together, the decussation of sensory information at the dorsal column medial meniscus pathway, the decussation of pain and temperature fibers when you're talking about the spinothalamic pathway, and then the pyramidal decussation, talking about the crossing over of motor fibers, you can then localize between what levels damage is. So we're going to do that a little exercise on this last. So how this would work is, let's say someone presents with specific symptom loss, and what side did they present with that symptom loss on? So think about pain and temperature. If pain and temperature is lost on the left side, I love using pain and temperature from the body to identify left or right lesion. If pain and temperature is lost on the left, then that means that the lesion has to be on the right. Right, and that's because pain and temperature crosses immediately as soon as it gets into the spinal cord. So pain and temperature is usually one of the ways that I differentiate left versus right. But now I need to figure out, did it occur in the brain? Did it occur in the brainstem? Did it occur in the spinal cord? So I look, pain, sensory information, and motor sensation was all lost on the same side. If pain, sensory, and motor are all lost on the same side, we know that pain had to decussate or cross as soon as it entered the spinal cord. Then this lesion has to happen after sensory and before motor crosses. So in order for that to happen, this has to happen above the region of the sensory decussation, which is above the decussation of the dorsal column medial meniscus pathway, which means that we are somewhere above the medulla, the closed medulla, and below the cortex if I see no cortical signs. Okay, so that's another check, because without that I couldn't tell if this is above the medulla, meaning it could still be in the pons, it could still be in the cerebellar peduncles, depending on some of the other factors that you would have to see to work this out a little bit more. And then cerebellar function, again, loss of cerebellar function is going to be on the ipsilateral side to the lesion. So if you lost the cerebellar function on the right, and that's going to correspond to a right-sided lesion. Now, moving on to another example, if you have pain and temperature loss on the left, again, pain and temperature loss on the left from the lower body, this is going to correspond to a right-sided lesion. And that's because pain and temperature sensation decussates as soon as it enters the spinal cord. Now, here we see sensory information is lost on the right. So now we have pain and temperature and sensory information are on different sides. What this tells me is that I'm above the level of the spinal cord, or I'm in the spinal cord for all I know, but I'm somewhere below the level of the decussation of the dorsal column medial meniscus pathway. So I'm below the dorsal column medial meniscus pathway because pain and sensory don't line up. When I go to motor, I see that motor loss is on the same side as pain and temperature. That means that this lesion had to happen before motor decussated to the opposite side. So this is going to tell me if pain and temperature / motor are lost on the same side, while sensory is lost on the contralateral side. This is going to tell me that this lesion is somewhere between the pyramidal decussation and the decussation of dorsal column medial meniscus. So this is telling me I'm somewhere in the right medulla, and this is specifically going to be in the closed medulla. And again, cerebellar function on the right helps correlate to the fact that you're going to have right-sided lesion. Although I don't use cerebellar function unless I absolutely have to, because it's sometimes hard to pick up on the question stem. Are they stumbling because they have loss of motor function? Are they stumbling because their cerebellum's messed up? What's the case going on here? So I try to avoid cerebellar function if I can. And then again, no cortical signs here. Cortical signs would be like Berkeley's aphasia, Wernicke's aphasia, things of that nature. They're specifically associated with the primary cortexes of the brain. So none of that here. So this tells me, again, corresponding to a right medulla damage. Then lastly, how do I recognize a spinal cord injury versus something in the medulla and brainstem? Well, then here I'm going to be looking for pain and temperature loss on the left, or it could be the right, but pain and temperature loss on the left on this example, sensory and motor are lost on the right. So that means sensory and motor are lost on the same side, pain is on the opposite side. So with this in mind, this is going to tell me that this is a spinal cord lesion. And if I want to localize what side of the lesion this is on, again, remember, sensory and motor, when you're in the spinal cord, are running on the ipsilateral side to their innervations. So this is going to tell me that the lesion is on the right. Again, cerebellar function would correspond with that. Pain and temperature crosses immediately as soon as it gets in the spinal cord. So pain and temperature loss on the left corresponds to damage on the right side of the spinal cord. And then again, here you would expect no cortical signs because the damage is in the spinal cord. So this would be a case of Brown-Sequard in a spinal cord. Now, this was an example that gave you pain and temperature, sensory, motor, cerebellar, and cortical signs for each one of these locations. That only occurs if you really had a hemisection at one of these regions, in which case in the medulla it'd be over. So take that with a grain of salt, but you can still use a lot of these components along with some of the other stuff that's provided within the question stem to get to the correct answer. So with that, I believe that'll bring a close to this video. I know it was a lot, but hopefully it was a glimpse into some of the important points that you're going to need to